Center ready, please.
I have the second presentation after this.
You're doing, continue, yeah.
Can we have
Surgeon's donor roll preparation in DMEC. Any questions we could take as we are waiting to line up the presentation? Is there any questions for the?
You compared two groups, was the sample size calculation done, and would those things be?
No, we did not take it as a sample size. We picked 75 arbitrarily as a learning curve experience. So we picked 75. The DSEC cases were already published in IGO back in 2007. So we sort of did it as a to mirror that study how the DMEC group is doing. Can I start?
Yes, yes.
Hello again, this is my second presentation. So this time I'll be talking about surgeon's donor roll preparation DMEC, MK medium and Cornisol medium preserved tissues. Again, no financial disclosures. So as we have seen in the previous, DMEC offers faster and better visual rehab, but the iBank prepared tissues are quite expensive, and surgeon preparation drastically reduces this cost. And unlike in DSEC, you do not need any specialized and expensive equipment. Also recently in the US, they're reporting more number of fungal endophthalmitis in iBank prepared EK tissues, and repeated freeze-thaw cycles during processing is a potential risk factor. So if the surgeon prepares it himself, this is potentially eliminated. And most of the Western publications deal with tissue stored in Optisol GS, Life4C, or organ culture. So in this study, we are looking at donor peeling time and DM tear rate during tissue preparation in corneas stored in less expensive Macquarie-Kaufman medium and Cornisol medium. We also look at the peeling time variation with donor age. It was a non-randomized comparative studies of surgeon DM peeling in 100 consecutive DMEC surgeries. A total 105 donor tissues were used. 52 were Macquarie-Kaufman and 53 Cornisol stored. The preparation was done by the same surgeon using the same technique. Macquarie-Kaufman tissues were used within 72 hours and Cornisol tissues within 7 days. The peeling time was measured by an observer from the surgical videos and was blinded to the media and the donor characteristics. So for the peeling time, we started with the initial 9.5 millimeter partial trephination. Then there is a 60-second staining with trypan blue. The peripheral DM remnant is removed. Initiation is started with the McPherson forceps along the trephined groove, and then gently using one hand to lift the DM and the other hand for counter traction, we peel the Descemet's membrane about 80 to 90%, leaving behind a small hinge. Now once this is done, a 3 millimeter skin punch is taken and a stromal punch is done. So the cap can either be removed completely or left hinged. Then the DM is floated back and the tissue flipped over. So now we have a 3 millimeter window, and an S mark is placed here on the Descemet's side. Once the S stamp is done and dried, we replace back the stromal cap and the tissue is flipped back to endothelial side up. Now a desired donor punch is taken. Again, a second partial trephination is done. Once this is complete, then the complete Descemet's is stripped off and placed back in the tissue cup, and then trypan blue applied. So this was the definition of peeling time for this study. The primary outcome measures was Descemet's peeling time in the 2 medium and the Descemet's tear rate during preparation. As secondary outcome measures, we looked at correlation with donor age, peeling time change with increasing surgeon experience, and behavior of paired tissues. So a total of 105 tissues were used. Three tissues were damaged completely and had to be discarded. 2 tissues were partially damaged during the initiation from the trephined groove, and then surgeon converted to manual dissect using the same tissues. So we had a total of 105 tissues, 91 donors. So 14 were paired tissues. Of these, 1 each was stored in MK medium and Cornisol medium, and 3 were stored in MK medium only. If we look at the donor distribution of the gender and the age, in both the media it is approximately the same. Now, overall peeling time in both McCurry-Kaufman medium and Cortisol medium was about the same. It was not statistically different. And the range of peeling is between 3.5 to 12 minutes. The 17 is actually one single tissue outlier. And the DM tear rate, we actually noticed more in the McCurry-Kaufman. We had 2 versus 1 in the Cortisol. And then partial tears, horseshoe tears or radial tears was 3 in the McCurry-Kaufman versus 1 in the Cortisol. However, the difference was not statistically significant. Now, we grouped the donors also according to the age, and we found that the peeling time about the same in all the 3 groups. The surgeon's experience, ease of peeling was most in the donors aged between 55 to 65 years. And for the paired tissues, the peel time was similar, irrespective of the storage media. The surgeon experience, as we see, this is the first 25 cases. It improved from 10 minutes to 5.4 by the end of the last 25 tissues. So there are various methods of DMEK donor preparation. Scuba and standard no-touch technique are the commonest. However, we could find only one publication about a surgeon preparing the tissue himself, that is Goravai. His peel time was about 10 minutes, and he also had some damaged tissues which had to be discarded and some which could be rescued, and the DMEK continued. He also noticed faster peeling time with donors more than 65. It was not statistically significant. Nowadays, there are reports saying that diabetic tissues are more difficult to peel, but we had 16 tissues from diabetic donors, and we did not notice such difference. To conclude, surgeon DMEK graft preparation is highly satisfactory with less costly media like McCurry-Kaufman and Cortisol. There is no difference between the 2 media in terms of peeling time and complication rate. Paired tissues behaved similarly, and peeling time improves with surgeon experience. Thank you very much for listening.
Do you believe that in your study, the experience of the surgeon probably resulted in the fantastic results which you have?
Yes, I mean, surgeon factor is one of the contributing things, but the graph that shows the improvement with time, that says that even an experienced surgeon has room for improvement, so that should be the same for everyone. The improvement will happen with time.
So your study methodology is a retrospective series of your experience?
Yes.
This is the DMEK part, at least, is the first case was actually the first case.
Yes, this is first case is the first case.
Okay,
yes.
right. And so down the line, you have measured the number of minutes.
Yes, yes.
Okay. You've not had any, when you're tearing it like that, you've not had any points where, I mean, I'm sure the video is very much edited, but still, you've not had any tears which still allowed you to continue?
We had.
Yeah, you have said only 2. Only 2 you
No,
had.
5 total. Like 3 had to be discarded, and then there was some peripheral horseshoe tears and radial tears which could be rescued, and DMEK could be continued with the same tissues.
Okay.